B dissection, I'm going to give the cardiac surgeon's point of view. So acute type B, we know that it's not as deadly as acute type A. However, still the mortality is around 10 to 15% in hospital mortality. But the biggest problem with the type B is the long-term mortality. In 5 years, almost 20 to 40% patients are dead if they're not managed properly. And you know, the incidence of type B is not very low. It comprises about 1/3 of all the acute dissections we get. This is the latest TEM classification that came out in the European journal. I think it's really important for everyone to know about this. So basically, type A, we know when it involves the ascending aorta, type B when it involves the descending aorta, non-A, non-B is when it involves the middle bit. Now, the entry location is very important. When there's no entry location that can be identified, it is EO classification, according to the classification. If the entry tear is in the ascending aorta, it's E1. If it's in the arch, it's E2. If it's in the descending aorta, E3. Then depending on which organ is malperfused, it's further classified into M1, M2, M3. So by definition, a type B dissection would have either no entry tear, which we don't know, or unknown tear, or a descending aortic entry tear, along with M3, which will be spinal, visceral, renal, or iliac malperfusion. Now, before I go into the concepts of management, I think this is really important for everyone to know about the INSTEAD-XL trial, which was done by Nenevar et al., who works at Brompton. So basically, patients who came with uncomplicated type B dissection, they were divided into two groups. One group had best medical therapy, another group had TEVAR. And it was shown that there was no difference in the mortality up to 2 years. However, in those who survived up to 2 years, the mortality in the TEVAR group was lower compared to the oral medical therapy group. And this was the main reason for that was the aortic specific mortality was actually much lower in the patients who had TEVAR. But you know, the survival benefit again was evident after 2 years. And same pattern followed for aortic related death, then conversion, reintervention, etc. What is a complicated type B? Complicated type B is a patient who has malperfusion, may have pain, organ malperfusion, pleural effusion, or has contained or free aortic rupture, persistent pain, or uncontrolled hypertension. Here you can see a patient who has malperfusion of the mesenteric vessels because the celiac trunk is actually pinched. Now, the new concept that emerged in the last few years is the high-risk features in acute type B. Because if you look at Nenevar's study, the uncomplicated group was a very mixed group. When they teased up the data, when they looked at the data in detail, they identified this group of patients who had high-risk features, and these patients were more prone to have complications. What were these features? If the primary entry was more than 1 centimeter, if the primary entry was at the inner curvature, because when the entry tear is in inner curvature, it can easily retrogradely go and involve the ascending aorta, hence it's more dangerous, as opposed to the greater curvature, outer curvature, where the head neck vessels are there to stop the propagation. And also the false lumen diameter is important. If it's more than 2 centimeter, or if the descending thoracic diameter is more than 4 centimeter, the outcome is far worse. And of course, there are other situations where they're called high-risk features. Now, if we look at the acute type B dissection, if it's uncomplicated, do nothing. So when I say do nothing, no surgical intervention. You need to make sure the patient is pain-free, need to control the blood pressure, need to make sure the patient is CT scanned and MRI'd at regular interval to look for signs of malperfusion. If it's complicated, something needs to be done as an emergency. If there are high-risk features, something needs to be done, not now, but soon, within the next 2 to 3 months. Now, two things are very important in deciding whether the patient should go to the vascular surgeons or to the cardiac surgeons. First is there any concomitant ascending aortic pathology? If the ascending aorta is dilated, then the patient should have some sort of cardiac surgical procedure as opposed to a vascular procedure. Also need to see at the landing zone, because that's really important. For TEVAR, we need a good landing zone. Now, looking at the concept of the management, if a patient comes with type B without any high-risk features, you manage the patients with oral medical therapy and regular follow-up. If the patient comes with high-risk features, which I've mentioned before, first thing you have to see, what is the ascending aortic diameter? If it's less than 4.5 centimeter, then you have to see whether the patient is suitable for a TEVAR. If TEVAR is possible, TEVAR should be the first option because it's less invasive. However, if the ascending aortic diameter is more than 4.5 centimeter and there are other features like no TEVAR landing zone, the patient should have frozen elephant trunk, which should be done in roughly 2 to 3 months. And same concept follows for the complicated. Only difference is instead of doing urgent operation, they should have emergency operation. Why is the landing zone important? Landing zone is important because for TEVAR, you need 2 centimeter gap between the subclavian and the TEVAR landing zone. If that is not possible, then you have to create a landing zone by doing a frozen elephant trunk. Also, you have to see whether there's any arch aneurysm, as I've mentioned, whether the patient has connective tissue disorder, whether there's a retrograde extension of the problem. And in malperfusion cases, TEVAR can be done sometimes, which may be followed by a frozen elephant trunk afterwards. This is a patient who presented in our institute with a Type B dissection. Later on, this Type B propagated towards the arch and became an intramural hematoma of the arch, needing a frozen elephant trunk, which we did. Frozen elephant trunk is a quite simple procedure. The mortality, morbidity is not much, especially when the patient comes for a Type B dissection, and the results are fantastic. This is the end result of this patient. You can see patient had some grafts as well. Now, sizing is very important in this kind of cases when you're doing a frozen elephant trunk. If it's an acute case, it's important not to oversize. So if the total diameter is 4 centimeter, you put a stent which is 4 centimeter. You do not oversize. Whereas in chronic cases, you will see the false lumen will be small, true lumen will be big, or vice versa. In those cases, we use a formula where we look at the length and width of the true lumen, divide it with 2, and then add 15%. So roughly, it's somewhere midway between the false lumen and true luminal diameter. Length is also important. We know that frozen elephant trunk or TEVAR stents, what it does is it reduces the blood supply, cuts off the blood supply to the spinal cord. So it's really important to think about the length. Whilst you need to cover the tear, entry tear, it's also important not to use too long stents, which can cause paraplegia. This is a study by Prevention's group in Texas, Dallas, where they have shown that if more than 15 centimeter stent is used, then the risk of paraplegia is much higher. Finally, take-home message, all these patients are unique. They should have personalized care, which is dictated by a complex aortic team, and there should be harmonization of terminologies, so the vascular surgeons and cardiac surgeons to speak to each other. And finally, early intervention is important in case of high-risk features and complicated cases. Thank you very much for your attention.